to go ahead and get started. And first and foremost, I want to share with you a little bit about what this is and why we do a 6-week series. During the work of the last couple of years with facilities, we've identified that the infection preventionist role is a role that is frequently in turnover and churn within a lot of facilities, and they struggle to keep infection preventionists in their building. And when we did a little deep dive into that with infection preventionists on that, one of the themes that we kind of heard over and over again is, hey, I've got the training, I've taken the course, but I really don't understand the role and how to apply the work within my facility, and where do I fit in, and how does that role work with other roles in the building, and kind of what's the expectation of the role. And so this is the fourth affinity group or work group that we've conducted. This time we've switched it up a little bit, and we're going to use the F tags, and we'll talk about that in one of the future slides, that relate to infection control and to your role as an infection preventionist. I believe that, sometimes we forget that the F tags really are kind of our guidance. They're our boundaries and kind of the expectations of our role within a nursing facility. And I always liked to use the analogy of like a dance floor. So when you think about a dance floor and you have boundaries on a dance floor, right? So if you have a dance floor and there's either walls or it's a wooden platform that you're dancing on, when you hit those boundaries, you can't go any further. And when I think about the F tags, I kind of think of those as those boundaries that we have to stay within. We can do the work how we choose to do the work, your policies, your processes, your nuances, as long as you stay within those boundaries and the expectations. So we're going to talk about that. And the goal of this series is to really just talk about the rules, the regulations, your role, and then to really give you resources and practical tips and tricks on how to apply all of that and make it usable for you in your role so that you really feel grounded and have a good understanding of the expectations as an infection preventionist. If at any time you have questions about what we're doing today, please go ahead, drop them in the chat, raise your hand. We can get to you that way. We will put the PowerPoint in the chat multiple times today so that you can grab it. If you came in a little late, it will be published here a couple times. And please feel free to use that, share it, and to use it even for training if you'd like. So here's the objectives of our 6-week series. We really want to help you understand the regulations, those F tags that are associated with infection control, help you understand your role as an infection preventionist, and then kind of I'd help you identify common gaps and commonalities that we see in 2567s, which is your report, your state survey report, and things that may lead to a citation. And then from that, we do have a hand raised, ladies, if you want to go ahead and jump in the chat with that. Obtain a clear definition of policy versus process and procedure, and then really kind of work with you. At the end of today, there is going to be a polling question where we ask you to give us topics that you would like covered, because we can adapt and change. We do have week 6 kind of open to address anything that comes up that you would like to have addressed or do a deeper dive into. So keep that in mind. In a work group or affinity group, it is meant to be interactive. It is meant to be peer-to-peer learning and learning from us as well as learning from you. So it is meant to be collaborative work towards a common goal, which in this case is just really helping infection preventionists with their day-to-day work and their roles. So this kind of describes what is a work group, and it is a group designed for collaborative learning, obviously sharing of best practices, and we're using it virtual. I will share that there may be technical difficulties at times. We apologize for that. It's another reason that we record it. And if at any point in time you're having difficulty hearing us or seeing the recording, but you can always let us know, send us an email, and we can kind of technically work with you on the backside after the event to try to walk through some of those technical difficulties. We also want to hear from you about your best practices, experiences, and areas of support or learning that you need. Then finally, the last identification with any peer-to-peer work, if we're going to be honest and we're going to build growth and we want to be collaborative, we need to be confidential and supportive. This is not a gotcha. This is not a blame game. We are not regulatory. Superior Health is 100% quality improvement focused. Yes, we are funded by CMS, but we are funded for the purpose of improving quality in healthcare providers, specifically nursing homes is our team's focus. So the work we do is confidential. It is collaborative. It is designed to help you guys improve quality. The three ladies that you see today all have long-term care experience. We all come with nursing home experiences of a variety of backgrounds. And I think the reason we all work for Superior Health is that we're driven by improving quality and taking care of Medicare beneficiaries. And I think Amy and Jess would agree with that statement. We're very driven that way. We want to see what's best for our elders. All right, so who is Superior Health? If this is your first foray into Superior Health, this is who we are. We are contracted by CMS for quality improvement and quality innovation. I know it seems a little weird, especially if you were only introduced to CMS from being the regulatory body of your Medicare, and that is correct. CMS does do regulatory, but they also fund quality improvement. And we work with providers in the CMS program, primarily skilled nursing, and we work in Michigan, Minnesota, and Wisconsin. That doesn't mean we won't have folks jump on these calls from other states, especially if your corporate entity is outside of those 3 states, but have homes in those 3 states. We have had folks jump on from other states just to learn about what this affinity group is, and that's okay. We are the Targeted Response Quality Improvement Initiative, and we work with Superior Health, and we were set up during the pandemic to work with facilities on outbreaks. These are the presenters. And here's our first poll. So rating the infection control topics, and Jess is going to drop that poll in here shortly. I want you to rate the topics that you would like more education on to improve your program. And if you can rate the infection, just give us the feedback on what areas you would like to have more education on. Your feedback is only going to make this education better for you and for your peers. So if you could please respond to this polling question, it would be greatly appreciated. I am not seeing any responses yet. Jessica, are you seeing anything come in yet? Ah, there we go. I think it's just a slow technology day today. So we will take these answers and kind of go through them. And that doesn't mean we're not going to cover all these topics, but it just means by looking at what your responses are, it'll give us kind of a good identification of where we need to do some more focus and deep dive on our information. So Jess, you got any feedback for us yet?
So it looks like staff education and training has been a pretty big leader.
I'm also
Isolation, enhanced barrier precautions.
Oh, and we have a hand raised. So
I'm going to end the poll.
Okay, perfect. So we will take that polling information. I'm going to share the results if you want to share the results.
Yeah.
And we will look at our training for the next 5 weeks and adapt and maybe adjust and increase or add some additional training. And we do have a hand raised, Jess, if you want to grab it, Jess or Amy. Okay, I'm going to keep going. Candy, I went ahead and just asked you to go ahead and unmute if you want to unmute and ask your question. All right, if not, we will keep going. All right, definitions. First and foremost, as we start any program, I want to make sure that we're all understanding what the words are that we're going to be using as we talk over the next 5 weeks. So with definitions, the first obviously is policy. And when you think about what a policy is, it's a course of action, and it is a defined course or method of action selected from among alternatives and in light of given conditions to guide and determine present and future conditions. That is a big definition. So your policy is your overall plan with the goals and acceptable procedures that you're looking to have and to put into place to achieve a common goal. So when you think about your policies, I want you could refer to this slide because policies and procedure are very different things. And I think sometimes we use those interchangeably and they really aren't. Procedure is the how. It is what you're going to do, how you're going to do it, when you're going to do it. It's that document that gives me as an employee how to execute my work. How do I do a catheter change? How do I toilet a resident? What do I do for hand hygiene, for example? What are the steps? The policy might be explaining to me the overall goal, but the process is the why. And you can refer to this slide. We will drop them in chat, but I think it's we need to have these definitions to just really kind of move forward as we're going through. Protocol, according to the dictionary, is a tradition or established way of doing things. And then guidelines are recommendations for best practices. So we're going to jump into the F tags. Today we're going to talk about F880 briefly, very high level, and then F882, your infection preventionist role, the role of the infection preventionist. Throughout the next 6 weeks, we're going to cover these F tags, some of them more in depth, others less in depth, some of them teased out, for example, water management. But we're really going to talk about your role as the infection preventionist in regards to these specific F tags. So let's jump into F880. F880 infection control gives us these words. These are the words that we pulled right off of the SOM, State Operations Manual. We dropped the link on this slide. This will be a live link for you in your slide deck. So if you've never looked at the State Operations Manual and you've never read the F tags word for word verbatim, I challenge you to go in and do that. You want a little light reading at night, a little entertaining reading, but I would encourage you to keep this link somewhere in your computer file because they do get updated on live updates. And we don't necessarily always know when CMS goes in and does the updates to the SOM. Sometimes they alert us because it comes out in a QSO memo. Other times they may do wording changes that are subtle, but mean things. So under infection control, it requires the establishment and ongoing maintenance of an infection control program. It is designed to provide a safe and sanitary environment for the residents that we serve. And, reading through all of these items, I do want to highlight a couple things because recently with the discussion around enhanced barrier precautions, we've been getting a lot of questions about two areas. And one is surveillance and the other is this, a system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases for all persons in a facility. You need to have written standards, processes, and procedures, policies and procedures. You need to have a surveillance system, and then you need to address standard and transmission-based precautions. Enhanced barrier precautions was added after this slide was written. And then identify when and where possible incidences of communicable diseases are reported. So I do want to highlight one part of this, and that is the surveillance system within your facility must not only be for your residents, but also your staff, visitors, and anybody that provides care or services in your facility on a contract or temporary basis. So think about contingent agency staff, think about your physicians and your providers. Your surveillance needs to include potential illnesses or transmissible diseases for all of those individuals. And then obviously the standard, the system for preventing, identifying, reporting, investigating, and controlling infections. This has come up in the past month with the outbreaks of recent measles. How you're identifying potential infectious or staff who have the propensity to possibly bring in an illness or virus such as measles. That just is something that you need to make sure that is in your policy and your process to establish a way to do surveillance for those items. And I know I'm going to get questions about that. So we'll talk about that a little further. So these are the goals of your infection prevention program. So when you think about F880, F880 is essentially the Bible of infection control. It is the groundwork, the basis for the rules and regulations around your infection control program. It sets the boundaries and it tells you what you should be able to achieve or should be achieving within your infection control program. And then these are the goals of an infection control program. And these have been more clearly defined by APEC and by SHIA, which are your Society for Healthcare Epidemiology of America, and then the Association for Professionals in Infection Control and Epidemiology. So these are the goals of an infection control program. You want to decrease morbidity. You want to prevent staff from becoming infected. You want to maintain residents' well-being, and you want to make sure that you prevent and control outbreaks. So this is something that has had a lot of conversation around since the enhanced barrier precautions got rolled out in the QSL memo. The Facility Infection Prevention Risk Assessment. Every nursing facility, and this is right out of the FTAG, nursing facilities will conduct, document, and annually review a facility-wide assessment that is called your facility assessment. It is not necessarily the responsibility of the IP or the DON or any individual one person. A facility assessment includes both your resident population, the resources that you need to care for those residents, as well as the types of staff that you have in your building to provide that care. The assessment needs to be done interdisciplinary. It should not be done by just your administrator. It should not be completed by a corporate entity alone without input from the facility. The assessment will identify resources needed to care for your residents during day-to-day operations and during emergencies. And the assessment identifies areas that you should have policies on, staff education and training, for example, staff competencies on, and it needs to be reviewed and updated at a minimum annually or with any change in the resident population or within your community regarding potential outbreaks. So the part for you as an infection preventionist in your facility assessment is that risk assessment related to infections. The portion that I would draw your attention to is if you've never seen your facility assessment, I would ask that you reach out to your facility administrator and ask to talk about or review with them your facility risk assessment as it relates to infectious diseases or illnesses within the facility and in your community. I'm going to give you an example. That's something that we do as we go through these series. So speaking of MDROs, if your facility is in an area where there has been Candida auris identified and your health department has made you aware that it is present not only in hospital systems, but perhaps in peer nursing homes within your county, your region, your city, and your facility risk assessment identifies that you are very low risk for that Candida auris, I would challenge you to explain or to consider that you're probably not low risk. If your hospital is being identified as having Candida auris and it is spreading in your community, you may want to look at your risk assessment for that particular illness or illnesses and bump that risk assessment to a higher level, and then actually have an adjustment and a discussion about what that would look like and what would you do for a response in relationship to that illness being identified in your building or a potential outbreak. And that's where I'm going to talk about the measles. So recently, I live in Michigan. Recently in Detroit, a child went into Detroit Children's Hospital. They sat in the ER waiting room and they were there for, I believe, 2.5 to 4 hours. And in that waiting room, it was very, very busy. And multiple people were exposed to that child who ended up being diagnosed with measles. So if I were a hospital, let's say I am a hospital within the Detroit Medical Center area and they have a risk assessment, their risk assessment for measles probably just jumped to high, or it should have jumped to high. And or if you are a nursing facility within 5 to 10 minutes of that hospital and you know that your staff utilize that hospital for their children, you may want to consider looking at your risk assessment and thinking about, are we at a higher risk for measles coming into our skilled nursing facility? Are we at a higher risk for whatever has been identified within our community on that risk assessment? That's what the facility infection prevention risk assessment piece is. It's separate and unique from an ICAR. It is part of your facility assessment, and it should be looked at annually for the illnesses, and it should demonstrate that you've considered information from your local health department, your local hospital reporting information, state health department, state epidemiology, wherever your sources are that you're getting for the tracking and trending of illnesses, and even your own facility admissions. Did you bring an MDRO into the building? Well, now you're at high risk for spread of that MDRO. So it's something that you should consider and talk about. And as an infection preventionist, you need to be part of that conversation and aware of that risk assessment. So if you have any questions about that, please feel free to drop them in chat, and we're going to get to those. We'll address them at the end. All right, infection prevention policies and procedures. They need to be written based on established practices, evidence-based practices. They need to be based on experts. Right now, we heavily rely, obviously, on the CDC to do our guidance, along with APIC. And they need to be written so that staff understand. It's plain language, so that staff can understand what to do, how to do it, and when to do it. You need to make sure that that policy and procedure has been reviewed by your quality assurance. Take it to QAPI, it needs to be reviewed. And if you're using a corporate policy, you need to make sure that it's individualized for your facility's needs. And then it needs to be updated when guidance changes, and you should do at a minimum review it annually and bring that into QAPI. So here are some examples of policies and procedures needed. Obviously, based on your risk assessment, based on your surveillance program, based on the precaution types, outbreak management, specialty services, if you're a facility that offers on-site dialysis or ventilator care, related to wound care, incontinence care, medication administration, vaccinations. And these are just examples. It's not an exhaustive list. One thing that we did want to drop in here for those of you that may be new, these are the 3 listings within your states of reportable illnesses. So I would encourage you, Michigan, by the way, has a state statute that these communicable disease reporting lists need to be posted or publicly posted for your nursing staff to have awareness of and who to contact. So you can download these. Usually these come out early January, late January for each of the 3 states with the updated list of reportable illnesses or diseases, and then who to report them to. And again, these are live links. So when you get the PowerPoint, you can go ahead and click on those, and it will take you right to that list to print off and have. At a minimum, I would encourage you to drop this list into your infection prevention program and refer to it in your policies under surveillance. All right, staff education and competencies. The regulations require your facilities to provide staff education. Staff education can be online modules, staff-led classroom presentations. It can be independent study. It needs to happen when they're hired. For example, bloodborne pathogens is a required education for all staff in nursing homes prior to work. With any changes in policy, procedures, or process, including products, if you change your wound care products, you change your cleaning products, you need to make sure that you've provided education with an attendance sheet documenting the proof of that education to your staff. It needs to be completed on best practices. So you need to make sure that if you have an outbreak or you have a variance of your infection control rates, you have something going on, for like example, a spike in urinary tract infections, you might want to do a root cause of what happens and then drill down, conduct education based on what you found, and include that in your staff education. When performance doesn't meet the standards, and then competency validation is also required. It is a separate entity. Competency validation requires education with an observation or a teach back from the staff, along with some type of written post test. So if you want to tease out and talk about the difference between competencies and staff education, we will talk about that when we get to F945, when I talk about staff education. But I think it's important for facilities to recognize that there's 2 components. Education is ongoing every day, and it should be written, documented that you've provided that education. Competency validation is something that you should do with all staff at a minimum annually to validate that they're competent, both with their demonstration of the competency and with some type of post test. All right, let's talk about your role. Are you exhausted yet as an infection preventionist? Are you overwhelmed? I feel you. This is a lot. But I want to stop and I want to say something to you all as infection preventionists, DONs, administrators, whatever your role is. I want to share with you that at the beginning of this pandemic, when we started, when all of us started, and I think myself, Amy, and Jess all worked in the pandemic. We were all in nursing homes or in healthcare entities during the pandemic. So we were there with you, right? We were there with you in that day-to-day craziness that has left a few scars on all of us. But I want to share that having worked in this role and seeing where we started at the pandemic with the ICARs and with the understanding of the infection control programs and not really understanding all of the importance of it, and where we are now, you guys are really smart and you have done amazing things in a very short period of time with your infection control programs. In the 5 years since we've started, 4 years since we've started with, during the pandemic till now, if you would have asked any of us back in, I don't know, 2018 about proper use of PPE and N95 fit testing, we probably would have looked at you kind of funny. But I bet now, if I went out and asked any of you in our audience, how do you do an N95 fit testing? You could rattle off the process for a fit test. You could rattle off the donning and doffing procedures, probably in your sleep, verbatim to me. And I think I just want you to realize how much education and training you have really adapted and adopted and have become part of who you are in your role. So while you don't see the progress maybe day to day and you feel like you're hitting your head against a brick wall, I want you to recognize that now that I'm out at that 2,000 feet level, I can really see the progress and I can see the impact that you're making on infection control. And I don't think you get enough kudos. So I want you to know that is a good thing and you're doing great things out there. So awesome job. So let's talk about you as infection preventionist. Let's talk about your role. So there is a specific F tag just about infection preventionist. It is F882. Again, at the very bottom of this slide is that SOM link. It will take you right to this F tag and it will tell you all the expectations about your role. So first, a few things to think about. The IP must, this is not shall or could, it's a must have primary professional training in nursing, medical technology, microbiology, epidemiology, or other related field, be qualified by education, training, experience, or certification, and work at least part-time in the facility, and have completed some type of specialized training in infection prevention and control. So your job has become a specialized professional role. 2018, 2016, probably not so much. The last 5 years have taught us that this role is probably as critical of a role as an MDS nurse in nursing home functionality and survivability. The overall success of a nursing facility does fall, you guys play a huge role in that overall success of a nursing facility's outcomes. So here's what the intent of F882. The intent of the regulation is to ensure that a facility designates your role. It's a qualified individual to complete this job, and that the job of this individual is somebody responsible for implementing programs and activities to prevent and control infections. And citations do occur for facilities not having a person in place with this required training. All right. So here is the validation and how to do the validation. And Patty created this slide, and I want you to understand we do see citations under this tag frequently on 2567s. And where I see facilities getting into trouble, and your surveyors are smart, because you guys report, and you might not know this if you've never worked as an administrator or on the back of house, your facility reports something called payroll-based journaling. It's called the PB&J report. That report goes directly to CMS and it delineates the hours of staff working directly with patient care. And it has your name and your social security number linked to that facility and the amount of hours that you worked in direct or non-direct patient care by your job title. So if you are the infection prevention nurse, and that's your designation, but when a surveyor, I'm not a surveyor by the way, but if a surveyor pulls your PB&J report and they see that you, infection preventionist, worked the last 8 weeks, 40 plus hours a week on the floor as a floor nurse, and your facility reports to them, oh yes, she's a full-time infection preventionist, do you think they're going to question that? Absolutely, they're going to question it. And we are starting to see them using your PB&J reports, your hourly reports, your payroll reports to identify if your infection preventionist is actually working the designated hours that you state they are on infection prevention. Now, if you are a small facility and you're a director of nursing and you have dual hats, meaning, well, you probably have a bazillion hats, but if two of your hats are identified as DON and IP, you need to make sure that your designated IP hours are truly designated and that you're hitting at least this part-time expectation per the definition under F882. So I'd encourage you to review this with your team in your building, review it with your administrator, review it with your director of nursing, and review it with regional and corporate entities if that's where this falls. I'm not going to belabor the point, but I just want you to be aware that that is the expectation. And we are seeing this tagged, and usually it's driven with an F880 tag or other infection control identified issues like in dietary, housekeeping, wound care. F882 will get tagged, potentially. All right, so here's the recognized IPC education. I'm going to guess that most of you probably took this training either through a CDC train, through ACA, through NIDANA. There are free sources, like the CDC course is free. Others cost a little bit of money. Some of you may have above and beyond have gone to APIC to get certified or other certifications, and that's excellent. I know that a few of the states have used some grant dollars to do free APIC training. So I encourage you to check with your state to see what they're doing for additional training, if that is a resource that you could tap into. So here is some more delineated roles of the infection preventionist. It talks about coordinates the IPC program for the facility. You track resident illnesses. You make sure to, you prepare many reports, right? So you're doing preparation, but you're also analyzing your data. You're the person that does the analyzation and does that tracking and trending. Maybe you're graphing. Maybe you're doing a line listing and a surveillance map of where the infections are in the building. And your little dots are all perhaps huddled around 3 or 4 rooms on one unit. It's up to you to take that, you need to analyze that. And it's your job to kind of do that deep dive, that root cause of why do I have 5 UTIs clustered in these 3 rooms? What could the root cause of that be? That's kind of the role of the infection preventionist, to work with the interdisciplinary team to kind of do that analyzation. And then you coordinate vaccine clinics, tracking of residents and staff vaccinations, perhaps. You coordinate surveillance audits with other departments. You need to work closely with dietary, housekeeping, maintenance, water management. You need to understand all aspects of F880, and you're kind of the gatekeeper or the coach for all of the players in the infection prevention realm. So, not going to believe we read through this. I know you know your role, but this is what F882 says your role should be. All right, so we're going to talk about auditing, and I'm glad that we're going to jump into auditing. I think there's a question in the chat, or Jessica, I'm not sure if you're seeing that, Jess or Amy. And you guys can interrupt me if it's something I need to answer right now. Please feel free. We're going to go into auditing. So auditing and observations. Auditing and observations is a method to validate that your staff are performing a specific policy or procedure as expected. So an example of that would be hand hygiene. So to do auditing, first you select your audit or observation tool. If you work for a corporation or a chain of facilities, you may have audit or observation tools that are expected to be conducted at a minimum monthly as part of your overall surveillance program as a company. If you don't, and you need audit or observation tools, you can come to our website. We'll give you we have a ton of resources. Your states have resources. CDC has audits. So you can always reach out. At the end of each of these PowerPoints, we'll give you emails. And sometimes you have to create an audit on something really funky that you see going on in your building, and that's okay too. So select that audit and observation tool. Confirm that the person conducting the audits is competent, for example, in hand hygiene. And I think this is important to think about. You aren't the only person that can do auditing in your building. In fact, you should make sure that you have other people trained to do some of these audits for you. Your interdisciplinary team is a good team to utilize to make sure that you've trained the trainer and that they're competent to do auditing. I would caution, though, that if you're having somebody else do the auditing, make sure that they're doing it as consistent per the policy as you are. So you might want to double check them a few times. But for example, hand hygiene. Hand hygiene is a really good audit that you can do, train the trainer and teach your department heads, your interdisciplinary team on how to do hand hygiene auditing. You observe for missed opportunities, improper technique, and staff need to be aware that auditing with feedback is being conducted. Auditing is not intended to be a gotcha. It is not intended to be a negative for staff and not intended to have negative outcomes for staff. The purpose of auditing is to check that your policy and procedure is working. Okay. In a just culture, we don't point fingers at individuals. We point fingers or we think about things in the terms of policy and process failure. So if you have staff that aren't performing hand hygiene consistently, you need to look at, your policy and your process. What does it tell them? Where's your ABHR hand, sanitizer located? Is it filled? Is it empty? Do staff have to walk extra? You do that root cause analysis, basically, is what I'm saying to you about auditing and observations. So if the data is telling you that there's something going on, that you're not hitting the mark with your policy, then you need to ask the why. So this talks about how you do your auditing. And then at your month end, you calculate your compliance rate, which is the number of compliant audits over the number of audits completed. And you analyze for patterns, trends, and revise your program. And then obviously report to QAPI. Here's a nice guide from the Agency for Healthcare Research and Quality, and it really talks about what a competency check versus an observational audit is. I think this is a great tool if you're struggling with this or you need more information about it. I think this is a great learning tool. It's really well written. I encourage you to look at that. All right, standard precautions. So it's the foundation of an infection prevention program. We need to make sure that staff are well versed on understanding what standard transmission-based precautions, enhanced barrier precautions. This should be part of your general orientation for all staff. It should be something that's trained on annually. And I would encourage that you include this in your competency for staff, their understandings of the different types of precautions. So in Patty's slide deck here, she did include the textiles and laundry. That is something that we are seeing an uptick, is environmental services, laundry, and dietary tags under F880 related to following precautions. So I would really encourage you to think about that. The bottom, we talk about following safe injection practices and making sure that staff understand what safe injection practices are. Again, something that should be included in your competencies for your nurses and things to consider, with that teach back is injection practices. So let's talk about some common F880 citations. If you go to, I don't know what this stands for, it's S&C QOR report. It's a free report that you can go out and basically it's the Survey and Quality Oversight Reports, I think is what it stands for. And week 6 will take you there, but anybody can go. It's public and you can go and you can pull out nursing home survey trends. And you can track and trend F880. You can drill down to your state and see the facilities that have been tagged for F880 within your state and at what level of F880. Now, it doesn't give you the actual survey wording, but you can utilize that to go to your state websites and look up your state, look up that nursing home or your nursing home by license and find the survey, actual survey language. I think Wisconsin and Minnesota both post the plan of correction along with that. I don't think Michigan does, but that's how we get our data. That's how we look at your common citations. Failure to perform hand hygiene is probably the #1 reason that we see F880 tagged still. And it's not following procedures and standards when providing resident care. Delivering laundry, delivering a food tray, medication administration, not having a barrier down during med pass, catheter care, glove changing, hand hygiene performance, placing clean dressings or dirty brief, dirty washcloth on a clean bedding or on the bedding. And, just when you look at them, you can see the tags, right? So those are common things that we're seeing. And failure to follow transmission-based precautions correctly. Again, signage not in place. Donning and doffing continues to be an issue, especially during surveys with outbreaks. All right, Failure to perform surveillance, analyze results, and implement appropriate measures to prevent spread. So failure to promptly identify and act on an outbreak. Remember that little mapping where I talked about that cluster? If you do nothing with that cluster and the state comes in and looks at your mapping and they identify that cluster, they're going to want to see what you did with it. So it's taking that next step, making sure that your records are up to date, your vaccination records, identify your infection records, your tracking tools, no audit results. Remember F880 states that we need to conduct surveillance and audits. If you're not doing audits or surveillance, you're at risk for having a citation related to auditing. How do you know that your policies and processes are working if you're not looking at it? How do you know that staff are doing hand hygiene per policy if you're not looking at it, if you're not doing some type of auditing? So there needs to be some type of process and outcome surveillance data that's required to be part of your infection prevention program. And then you're also supposed to have follow-up and analysis of that data. So what did you do with it? Did you do additional education? Did you do a plan, do, study, act cycle? Did you take it to QAPI and do a big project on it? No monthly or quarterly reports, and then your policies and procedures not being updated or reviewed annually. Those are the top things that we're seeing trending in F880. So F880 continues to be on the top 10 cited citations. The Chicago region, which includes Michigan, Minnesota, and Wisconsin, continues to have the highest number of F880 citations nationally, 452 citations so far since the fiscal year began on November 1, 2024. And in fiscal year 2024, October 1st, 2023, Michigan had 56, Minnesota 53, and Wisconsin 44 citations, and then 2 immediate jeopardies in the region, which is a decrease. I do want to give that call out, that the decrease of 2 immediate jeopardies. Back in 2020, I don't even want to talk about how many immediate jeopardies were given for F880. All right. Other common F880 citations: environmental services, dirty resident equipment, linen handling, uncovered clean linen, carrying linens next to the body. That continues to be an issue. When we talk about environmental services, we're talking about terminal room cleaning and then starting to clean, not cleaning cleanest to dirtiest, actually cleaning the bathroom first and not following the policy and procedure. Dirty resident equipment being observed in shower rooms or being utilized without being cleaned in between use of residents. So, and then here's the resources that we use today to create this. And so all of these resources are live linked for you. So when you grab the PowerPoint, you can utilize these resources to take you right to the source to review and investigate and talk about more with your team. All right, we are at the end. So the next poll, Jess, if you want to put this in for me, what keeps you awake at night as the infection preventionist? If you could just honestly answer, and again, these polls are confidential. We don't see who answered what. It's a confidential poll. So if you could tell us what things that you feel or cause you the most stress, what's causing you the most anxiety about your role as an infection preventionist? If you could put that in the poll that Jess will bring up shortly. Guys are jumping on this one. I know this is a big topic. I think everybody has stress, right? And your job is difficult. It's a difficult job. I know you're often not referred to in kindly terms, especially around PPE with staff when you're doing accountability rounding with staff. Yeah, staff not doing what they're supposed to. I think that seems to be the highlight. Correct, Jess? Am I correct on that?
Yep, that one's in the lead, 83%.
Yeah. Do you want to go ahead and end the poll and show everybody where we're at? All right. All right. Thanks, guys, for that. We will talk about that too. We'll talk about giving you some tips and tricks on how to help with staff and managing your staff and holding them accountable, and ways to get staff engaged. It's tough. The environment is tough. So, Over the next few weeks, we're going to cover these areas that you've identified as challenges to your IP program. We want you to ask questions, comments, sharing, and we want this to be beneficial to you and your IPC program. So with that, I am going to open it up to questions, and I see we have some things in chat. Jess, Amy, is there anything that we need to address?
We have a comment about, thank you for doing this. It was well done. That survey, or S&C stands for Survey and Certification, and that it would be nice to add the APIC certification information for long-term care IPs, the certification for infection preventionists.
Absolutely, we can do that. Any other comments or questions? Right. So the series is a 6-week series. We will be doing them on Thursdays. There is a gap the week, I believe, of Memorial Day. I think we skipped that Thursday because of a conflict with another webinar within Superior Health. So I believe we pick up that following week. If there is a topic that you would like for us to cover, I'm going to share again. I'm going to share my screen again so you guys can see. These are the topics that we will be coming up that we're going to talk about. But we have bandwidth to change these up if needed. So these are the upcoming topics. We're going to talk about surveillance. We're going to do a really deep dive into surveillance, hand hygiene, PPE, transmission-based precautions, outbreaks. I'm going to do a deep dive with you into water management, and we're going to talk about environmental issues. And then we're going to talk about QAPI and your role in QAPI. I will do on the last day a tour of the Superior Health website. Our website is huge. It's a behemoth. And if you've not really had the time to like deep dive into it to find resources, it can be a little tricky. So we're going to take you to that website and we'll walk you through how to find things. We do offer on-site visits with an infection preventionist, IPC well, and then we can do education on any topic that you find that would be helpful to you in your role as an infection preventionist. Just give us a shout. And here's the emails. Those are live. That's from myself and Patty Leonard, who were the presenters for today. Patty helped with the slide presentation. She couldn't be here today, but I'm Jana and Patty, and then we have Jessica and Amy, and they will be taking on roles in the next 6 weeks. You're going to hear from all 4 of us, which I think makes it a little bit more fun for everybody to hear different voices and different perspectives. Is there any other questions before we cut everybody loose today?
Jana, there are a few in the chat.
Okay.
Somebody would like to know where they can find this video posted. They were unable to join earlier.
So we will have it posted on the Superior Health website. If you want to email me your name, I will make sure that as soon as it hits our website, I send you a link to it, and we can do that. So, and then we will I'll ask our comms department if they can get us a link to it so that we can post it in the next week. Maybe we can just, every week drop that in the chat of where the prior week's videos are, so staff can, or people can find them. And then I see a question. Did you answer that question, Jess, or you want to answer that question about the indwelling device?
So yeah, the enhanced barrier precautions are going to be a forever thing as long as a resident has an indwelling device. So even if they do not have an MDRO, the fact that they have an indwelling device is going to place them on enhanced barrier precautions so long as they have that device. If they would have that device removed, like they had a Foley removed or a feeding tube removed, and they did not have an MDRO, then you could stop the enhanced barrier precautions. Otherwise, it's a kind of a forever thing.
Any other questions?
There is another question. So when they are in the therapy room, the therapist has to wear gloves and gown in the therapy room.
That is correct.
Mm-hmm. Yeah, and I think that was clarified. I was on a call today. Wisconsin did a presentation today. Michigan did one yesterday. And talking about risk assessments, right? And where you look at your risks. And there was a question that came up about group therapy and whether that would be considered like an activity, where in activities you wouldn't need enhanced barrier precautions. And I would caution you to look, I would be cautioning facilities that are looking for loopholes on how to avoid having enhanced barrier precautions, because without good documentation, care planning, and involvement of a really good assessment of that resident and their risk to others, I think you're opening yourself up for, you're going to make yourself vulnerable if you're not utilizing enhanced barrier precautions per the CDC guidance. So
there is another comment, let's see, a patient or PT just asked if she had to gown up with a resident on EBP if she was doing exercises with her, not touching her. I said no, but if transferring and doing PT exercises with her, she would need to gown up.
yeah, and I would, make sure that you document that, right? I would make sure that it's in her care plan, that therapy has it in their plan of care, that therapy can speak to that and why they would or would not use enhanced barrier precautions. The therapy piece of this is going to be very tricky to navigate. It is going to be probably your biggest discussion point in my mind. The other item with enhanced barrier precautions that I want to make sure people are aware of is the use of reusable gowns is really frowned upon. It is a very high risk behavior. So if you're considering using reusable PPE, I would caution you to think about that and to look at the risks involved in that. Very high risk behavior, high risk for potential of spread of illness. And it's something that we're hearing from all 3 states that they're not going to look favorably upon. It's going to be very much scrutinized. Yes, you are correct. Other residents may be put off by this and they will know their enhanced barrier precautions. And what we're being told and what we're hearing from CMS and CDC on this factor is that residents don't have a choice. So resident rights in this situation, it's not a resident rights to refuse staff using enhanced barrier precautions, because the safety of the facility and the residents as a whole trump the one need of the resident. Counterintuitive to everything that we think about, I know that, but that is the statements that we are getting. That is what we are being told is the guidance. And so, Amy, Jess, if you've got anything to add to that.
I think it just kind of goes akin to our standard precautions, use of gloves. We don't ask people if we can use gloves. We do it because it is the safest thing for everybody involved. And so that's, I think, kind of the attitude we have to go into enhanced barrier precautions with. And not be sharing information about other residents, just sharing that we're doing what we need to do as a facility to keep everybody safe.
So here is, and I apologize, I put the wrong link in earlier, Jessica, but here's the link to the survey. So if you guys could give us feedback on the survey, if you have, I think, Jess, thank you so much, Jess and Amy, for putting the correct slides in. I apologize for that earlier. But here is a survey. If you could complete this on how we did today with this and give us feedback on the presentation, we will use it to tweak and adapt over the next 5 weeks. If you have peers or other facilities in your organization that would like to join, please feel free to share the link that you have. Tell them to go on to Superior Health Register. They need to register in their own name and with their facility so that they can join us. And it looks like we have one more question, a couple more questions.
So the confusion about staff and being in the hallway is pretty common. I did get clarification from CMS is that they're not expecting use in common areas and in hallways. Those are areas where you would not use enhanced barrier precautions with your residents.
Unless it was this extremely, like, I could think of potentially like if a resident's on the floor and they've fallen and you're using 2 people to get them up, right, Jess? I mean, if it's like a high risk behavior perhaps, or high risk exposure, I mean, it's a hypothetical, right? It's the anomaly versus the norm, I guess, would be that. Yeah.
So yeah, therapy does walk residents in the hallway and they are not expected to use enhanced barrier precautions in the hallway, just in the therapy room.
Yep.
There is question about signage. Does the signage on doors have to stay EBP?
Now, you can utilize however you choose to per the guidance on how you choose to have it identified for your staff who is on enhanced barrier precautions. However you choose to do that, you need to make sure that your staff can regurgitate and reverberate that back to a surveyor if asked. So if you're not using an enhanced barrier precaution signage, and in fact, they're discouraging that because of, resident rights and privacy. However you choose to identify those residents that are enhanced barrier precautions in your facility for your staff, just make sure that they identify and can share that with the surveyor if questioned. I know a facility that is using a sticker format on their like nameplate above their bed. There's the same sticker. It identifies something. There's different ways to do that. Any other questions? If not, I hope this was helpful, and thank you all for attending today. We look forward to seeing you next week.